Welcome to New Perspectives on RVN Television. I'm your host, Barry Lefkowitz. Those of you who generally follow my show know that we have done a series of shows on human beings and their human experiences. Today, we are taking a look at the stark disparities in maternal health in hospital settings in the U.S. that has persisted for decades despite our supposed continued advancements in medical care. How is it possible that Black women and or their children die in birth at a rate 41.4% to 13.7% for white women? Approximately 700 women die in the U.S. each year as the result of pregnancy or complications. How is it possible in this day and age? The U.S. is not a third world country, and yet we have a shocking figure that we're looking at. A quote from our guest today: "Unfortunately, hospital administrators and clinicians, quality and safety experts, and health insurance plans further silence Black patient voices and undermine the power of Black mothers and birthing people in telling their own hospital birth stories and having others see. Hear and believe them." My guest today is the nationally renowned OB/GYN doctor of over 20 years,
Yes.
Dr. Karen Scott. Welcome, Dr. Scott.
Thank
We're so
you,
pleased to have
Barry.
you here with us today. First of all, I think it would help, for the audience to get to know who you are.
Yes.
If you could give us, your background.
Yes. So by training, I am a board-certified obstetrician gynecologist, or an OB/GYN, for the past 21 years. This summer, 2023, I am also trained as an applied epidemiologist, which means I study the distribution and the drivers or determinants of events or health outcomes. I'm also a public health scholar, and I am also a quality improvement and implementation scientist and practitioner, which means I am constantly evaluating the quality, value, and safety of healthcare in hospital settings. I'm also advocating for best practices, policies, and processes that can allow us to continue to provide optimal care to all people in hospital settings. And I am born and raised in Nashville, Tennessee, and I'm back home as of the last year.
Oh, that's fantastic. I've been to Nashville and love it.
Yes.
As a doctor,
Yes.
what drew you to concentrate your time and effort, because your whole time now is spent in dealing with what you call racism in birthing for Black women?
Mm-hmm. So I actually never wanted to be a physician. I made that decision in college, yes, almost like the last 2 years of college. And I always wanted to be like a scientist, a molecular biology scientist. And what...
You wanted to be a nerd.
Well, yes, always a nerd, always.
Okay.
I think what happened is that me looking at, the experiences of Black women in my family, in my neighborhood, always wondering and being curious about how Black women make decisions around their household, their partners, their family, church, religion, spirituality, healthcare, all of those things, and looking at how, gender and or race impacts our access to opportunities and options to live an optimal, thriving life. That's always been my curiosity.
Okay.
Then when we get to college, I was introduced to essentially a course called Biology of Female Sexuality. And it was essentially talking about, and I'll summarize, how the combination of a civil rights movement and a women's rights movement was needed also in healthcare. Mm-hmm. Because of traditionally, men were physicians, women were patients.
Right.
And that power differential between who gets to determine what happens to the woman's body. And I was like, honestly, I saw medicine as the final frontier. I'm a Trekkie, and I was like, medicine is the one place that I feel that I can give of my talents and my gifts, my divine gifts, to look at how racism, classism, and sexism, gender oppression all kind of collide together to impact not only what is happening to us in our bodies, in society, but also the health system and how health systems and structures, right, create a narrative sometimes of our unworthiness and how that unworthiness plays out and how systems and structures within the health systems and hospitals continue to deny our right to like life, liberty, the pursuit of health and happiness and wholeness. That was like, I was like, aha, I would rather want to be on kind of that social movement of reforming healthcare as opposed to being in a lab with some test tubes and chemicals. I just felt in my heart that I was more capable of making change in the way that would impact the people that look like me and my family. Like I saw it as a way to like, this is what I've seen happen in our family. I don't want other families to necessarily go through this. And I can be better utilized as a Black woman physician.
Now, you emphasized the word 3 times when you were talking unworthiness.
Yes.
Could you explain to us what you mean by that?
Yes.
In layman's terms.
Right, and I will do my best. What I mean by unworthiness is, it seems like, just waking up in the morning and having desires and of wanting to like experience joy, experience pleasure, experience peace, laughter, being able to have that desire be manifested in actions in some part of your life, whether it's in your partnerships with, romantic or business or friendships, or is it in the...
Which should be more than just Valentine's Day.
Exactly. But like how do we connect what our desires and intentions of our lives to actually impact what's happening in our life? And so there are forces at play that sometimes deny people that opportunity to live their best life the way they see and define it, the way they want to navigate in the world, to be their best, most authentic, radically unapologetic self. And so that to me is like, I am worthy of that. I'm worthy of becoming what I feel is best for me to become and to do those things. When we look in healthcare, there are forces at play, people, their language and their behavior, who can create a story of someone's unworthiness. For example, when we look at folks who are pregnant, right? And the different decisions they have to make around not only healthcare, but housing, food, nutrition, jobs, even partnerships, including sex. There are kind of labels that are put on what a mother or a parent should do and should not do. And I think that constrains and controls what people say we should do versus what we want to do. And I mean, of course,
being politically correct.
I know, I'm trying to, right, there are notions around motherhood, right? Like who is fit to be a mother?
Okay.
Who is fit to not mother? And depending on race, class, gender, insurance status, language, nativity, where people were born, where they live, there are others who are afforded so many opportunities and options to be their best self. But if everyone's not that definition of that self, then the rest of us don't even get to get on, quote unquote, that ladder or that ceiling to even get to that place. And so what we're seeing in healthcare, particularly in obstetrics or in pregnancy, that some people are given grace for, let's say, having an addiction, right? Saying that that's a disease, where other people are like, well, something's inferiorly wrong with you.
Okay.
When the combination of, let's compare what's happening now with the opioid crisis, right?
Sure.
It's seen as an addiction, a disease that people need help. There's so much more grace given to people who are suffering through addiction. See, I'm saying suffering, right?
Right.
Now let's go back to the 80s, the crack era. Crack baby, crackhead, crack mom, those were terms that were given to people that looked like me, who are still suffering with an addiction, with a disease. They were criminalized, right? They were told they couldn't parent. They were arrested. Their sentencing were extended depending on the type of drug that was used. Those are not things that we're hearing now that we have. We actually have whole opioid, use disorder fellowships in my field. We didn't do any of that in the 80s for people that looked like me. So that's what I mean by, particularly in different systems, we know in law enforcement and housing, but also in healthcare, there are people in power who are deeming who's worthy of being the best optimal mother that they want to be. And even if there are things like addiction or being unhoused or being unemployed, there's still grace and support and resources extended to them that we're not seeing extended in the same or optimal way or equitable way to Black mothers and birthing people and families. That's what I mean by worthiness.
Okay, well, just as a note, consistent with what you were talking about, the incarceration rate for marijuana violations
Yes.
is 5 to 1 in terms of Black versus Caucasian,
Yes.
even though the statistics show that the use of marijuana is 50-50.
And
so I just share that with you.
Yes, that's exactly the difference.
Now, getting back to the birthing issue, if nurses, doctors, and other health practitioners are all trained for handling pregnancy in a hospital, how is it possible that there's a different level of care for a Black woman versus other races? Because you've been trained to handle something in a particular way. So
that's a great question. So let me start with in this way. So yes, professionals in nursing and healthcare, medicine, we are trained to recognize and respond, right, to a concern, whether it's urgent or non-urgent or emergent, right? There's certain steps and protocols that we follow. We are trained in that way. The concern is that though we are trained to respond to emergencies or urgencies or to a health concern, there is a variation in how we respond to the medical or social concern that a patient, particularly a Black patient, will report in the hospital, in triage, in the emergency room, on labor and delivery. It's the way, how we are responding that differs based upon who is that patient and where they come from, what their skin color looks like, again, what language that they speak. And so that variation in the delivery of care is actually the driver of these differences or really inequities in people's capacity to experience pregnancy, continue the pregnancy, live through birth, and live beyond a year after your child is born. And what some people may think, well, and I'm just going to be really frank, that, well, does the Black mother, is she educated? Did she have health insurance? Did she actually go get care? Did she, know that she was pregnant? Like all these questions, which are part of victim blaming, right? We have multiple research studies that show when you control or remove factors like someone's age, their body mass index or their weight, their pre-existing medical conditions like hypertension, diabetes, which happens in pregnancy, even when you remove the prior experiences of having a cesarean surgery or abdominal birth, when you control for those things and put them to the side, the differential rate and the rise of dying or almost dying still is disproportionately impacting Black mothers and birthing people. So it's not that we don't have access to care. And I'm not negating that access to care is an issue. What I'm saying is that it's not the individual characteristics or behaviors that are driving these inequities in this death and dying gap. It's actually the variation in the quality and safety of care that a healthcare team will offer to a Black mother, a birthing person, compared to all other mothers and Black birthing people. And essentially dismissing, denying, negating our concerns, our pain. If we say that our abdomen hurts, especially around pregnancy or birth, when someone says they have abdominal pain, it could be the placenta, it could be something happening with the baby.
Sure.
It could be after a birth, and actually the uterus, which holds the baby, is filling with blood. And the person experiencing that notices or senses, perceives something's not right.
Because they know their body.
Exactly. But when the hospital team, whether it's the nurse at the bedside, the physician, the midwife, the anesthesiologist, there's a repeated pattern of denying the existence of that concern or dismissing it, minimizing it, and saying, oh, you're okay. For example, a Black pregnant mother comes to the hospital and her pressures are high. If her blood pressures are high above a certain level, we are trained to respond to evaluate for a condition called preeclampsia, which the name doesn't matter, but the behavior in responding does matter.
Sure.
When the nurse says, oh, you took a bus here, 3 buses here, your blood pressure is supposed to be high. Now, granted, that may be true, but it's a both and. What also could be true is that she may have preeclampsia. So now you've told her you live a stressed life as a Black woman, a single mother, 3 children, you're pregnant with your 4th. This judgment comes into play. You try to say your stressed life is why you have blood pressure elevation. I'm going to discount it because it's not real. But if you were to change the race of that person or change the marriage status of the person, or you were to change that maybe the race of their partner, then immediately you would see, oh, your blood pressure's high. Let me do all the things I'm trained to do. Draw bloods, get tests, ask you questions. Maybe I'll go get the actual physician to come evaluate you. Or maybe I'll have the specialist, the maternal fetal medicine specialist evaluate you. But none of those steps are happening in a timely, optimal manner, which is why some of the leading causes of death in our country, particularly around Black people, cardiovascular hemorrhage. And it's not bleeding.
Speaking of timely,
yes,
we have to do that thing known as a commercial break, otherwise they're going to throw us off the air here. So please stick with us because Dr. Scott has a tremendous amount of information to share with us about the whole issue of healthcare in hospitals and how actually it is differential between races. So don't go away, we'll be right back.
Hi, I'm Bob Hochgertel from Kings Road Brewing Company. I'm here to tell you about a brand new show on RVN television called Cooking with the King. Each week, we're going to taste and sample some of the best beers the Kings Road Brewing Company has to offer. And we're going to talk to area chefs and restaurant owners as we pair our beer with their signature dishes. We're going to teach you how to cook and eat like a king. Cheers.
A stroke can be easy to detect. A loved one can't speak, perhaps they can't move. But there's another sign of a stroke that many of us can't see. It's called spatial neglect, and it can occur during or after a stroke, causing distorted visual movements. Fortunately, there's a solution by using optical prism technology during rehabilitation. If you or a loved one have experienced a stroke, ask your doctor about spatial neglect. Spatial neglect. See the whole picture at KesslerFoundation.org.
Are you burned out, disenfranchised, disengaged, extremely distracted? Do you feel that you're lost in semantics, over-leveraged, overwhelmed? My name is Lisa Fratelli, and I have a show on RVN TV, always streaming. The name of the show is The Neuroscience of Wealth and Well-Being. The intention of this show is to explain how you can get back to homeostasis, flow states, creativity. It's highly correlated with happiness and well-being. So you can get out of overwhelm, get out of burnout, not feel distracted, and get back to your life. You will hear from experts who will get you back on track so you can enjoy your life again. RVN TV, we're always streaming.
Are you part of the Great Resignation? Are you a business owner that would like to diversify your business holdings? Have you always had an entrepreneurial itch but did not have a concept to get you started? Milestone Franchising represents over 500 franchise concepts across 30 industries. Concepts range from $20,000 to $6 million, and they can be home-based, office-based, mobile, or brick and mortar. We guide you through the process to select which concept is best for you based upon your core competencies, your interests, and your financials. Milestone Franchising is part of the International Franchise Professionals Group, IFPG, and will bring a host of resources to assist you in your quest for business ownership. When you work with a certified franchise consultant, you gain access to a professional process that helps you succeed in your search for the right placement. Finding the best placement for you within the franchising world of 4,000 concepts is the objective. Matching your skills and goals with a culture that fits you best is the priority. For a free consultation, visit our website at milestonefranchising.com. Milestone Franchising is here to lead you in a new direction.
Hi, I'm Bob Hokerl.
Welcome back to New Perspectives on RVN Television. We are having a critical conversation in regards to the whole issue of the differential in healthcare in hospitals for Black women versus other races. And I know that just before we came back on air, that you wanted to talk about some scale or something.
Yes.
So I'll let you do that, but I also then want to have some follow-up questions from this whole explanation you were giving about the different care and the fact that they don't take the same commentary from a Black woman as they do from other races.
Right. So thank you, Barry. So in following what you've just stated, there's been work done by Black women scholars in the social sciences, in the humanities, in public health and maternal child health for like 30 plus years, such as like Fleda Max Jackson, Leith Mullins, like shout out to, our elders who have been stating these things, this differential response to Black women and people's concerns throughout their pregnancy, course of pregnancy. And most recently, I would say like in December 2018, Dr. Donna Ian Davis, who's a Black feminist anthropologist and a doula, public health scholar, and more,
What is a doula?
A doula, oh, okay. Well, a doula is a birth professional. They are trained to provide support and advocacy to traditionally around people who are experiencing pregnancy. They can be at your prenatal visits. They can come home. They are a birth professional who doesn't provide medical or nursing advice, but they establish a relationship built around trust. They get to know the pregnant or birthing person and their family and their surroundings, probably next to the person themselves as the expert. They're like the next in line, and really having a holistic, very meaningful relationship and perspective of that person, and knowing their desires, their intentions. So they provide their support, social, emotional, mental support, and advocacy in prenatal care. They can come to a person, accompany them in their visits. They can also come to them in their homes, really. So in healthcare, people will usually hire a doula to be with them around pregnancy, around labor, birth, even postpartum. You can also have a doula around any part of healthcare. I personally myself asked two of my nurse friends, one is a nurse and public health scholar, one is a midwife, to be my COVID doula, because I myself was navigating a very violent healthcare system in Oakland, California, and I, even as a physician, needed to ask someone to be a doula, a COVID doula for me, because of the mistreatment, the dismissiveness, the degrading type of care and communication that was provided to me in the emergency room and during telehealth and during in-person visits. So,
even though you are a renowned scholar and doctor.
Yes, I had to have someone advocate on my behalf. I actually broke down in tears crying because of how degrading and dehumanizing the experience was. I literally could not even talk anymore. And so special thanks to Jessica Roach in Ohio and Ana Delgado in California for literally being on my cell phone during visits of telehealth, but also in person, because of what I look like. Being a physician, having an MD is not going to protect me from systems that are going to treat me as an unworthy person because of virtue of me being a Black woman.
Okay, so go back to where you were talking about your scale.
So I was ending with like, so we know that it's not the individual's behavior or characteristics alone that's the driver, right, for these differences in this death and dying gap. So if it's not the individual, then it's something about the quality of care in the hospital setting. So how do we evaluate that quality, that safety of care, using a different lens that doesn't victim blame or shame the individual, but really get at the core of, is it a combination of gender and race oppression or sexism and racism that happens not only in medicine but in obstetrics? So that brings me back to Dr. Donna Davis, who, the Black feminist, anthropologist and doula, who defined this phenomenon and this analytic or framework called obstetric racism. And essentially, for the audience, it may be hard to hear, but it's essentially just a recalibration of U.S. chattel slavery and colonization in this country. So the way in which the profession of obstetrics, which I am a part of, sees, perceives, treats, cares, or mistreats and miscares for Black mothers and birthing people is really in alignment with the ways in which they treated us or saw us like as property to be controlled and dominated, that we could not make our own decisions around our bodies, right? And having sex and reproducing and building a family, but also what happens to us in the healthcare system. So I took that as a leading cause of what we're seeing and the way people mistreat us or deny us of optimal care, or there's lapses in diagnoses, or there's intentionally causing pain. All those different dimensions of obstetric racism, I got permission from Dr. Donna Davis to actually translate that theory into a measure called the Patient-Reported Experience Measure of Obstetric Racism. The reason why that's important is that I don't know if the audience is aware that in the electronic health record, there's nothing in that record, right, that health plans, health departments, right, they make decisions around reimbursement. They make decisions around allocation of public health resources off of what's in the health record, off of the birth certificate, even after on the discharge summary. But all of that data, which is important, it is lacking the patient's perspective. None of those things are, like if we speak of ourselves as patients, we don't actually get to drive or determine any of those things. So I was like, how do we build in that gap between the hospital's intention, right, of providing high quality, safe care and the actual community impact of feeling disrespected, dismissed, of being harmed emotionally? How do we connect the two? Because right now, all of the different ways of determining what's of value, what's safe, what's high quality is all determined by the system, none of it by the patient. So I developed and validated this survey instrument that looks at these experiences of humanity, of kinship and racism, to ensure that the patient is involved in the evaluation of quality and safety, not just the system saying, look at us, we're great. We use our own measurements and our own instruments. Why don't we actually see what the patient and community is experiencing and have that be the goal, and not just here are these outcome metrics that sometimes actually have nothing to do with the experience of care, but more about what the system would like for us and health plans to believe is like the standard of care. So everything that I do is always about bringing in different truths, different perspectives, because I think it's important for the patient and the system together to be able to say what's high quality, what's of value, what's safe.
Would you believe that we've run out of time for this first half hour? Fortunately, this is actually going to be a two-part series with Dr. Scott. So please make sure you tune in next week, and you'll see part 2 as Dr. Scott will help explain how we can, in fact, lower the incidence of death, and actually using some of these metrics will actually be able to lower deaths for across the board in terms of birthing, if I'm correct.
Yes, it's possible.
Okay. So thank you for tuning in this week, and as always, because we're still dealing with some new virus, some new COVID. There's the flu is out there, pneumonia is out there. So please, stay safe, stay well, and we'll see you next week.